If you are providing mask ventilation in the OR, it is absolutely essential that you have some way of monitoring how effective your ventilations are being. An important aspect of this monitoring is this screen here. This is the control screen for the ventilator. It allows you to change ventilatory functions, but more importantly, it gives you real-time feedback on what you're doing and how effective your ventilations are. One of the most important things you need to watch closely is this white waveform in the center of the screen. This is called a capnograph trace, and its peaks show the presence of a physiological amount of carbon dioxide in the expired breath, and the troughs are when the expired carbon dioxide falls to zero during an inspiration, that is when you squeeze the bag. This is critically important information because it's telling you two things. First, that your attempts to keep the airway open are effective, and the second thing is that your mask ventilations are adequate to eliminate carbon dioxide. If this trace disappears, your efforts at mask ventilation are failing. Of course, all your effort and all your skills are for nothing if you are ventilating the patient with a hypoxic gas mixture. In that case, it doesn't matter if the airway is open or how effective your ventilations are. Things are going to go very badly for the patient very soon. This portion of the screen shows exactly how much oxygen is being delivered. Here we see 1 litre of air, 1 litre of oxygen, a total flow of 2 litres, and the inspired oxygen concentration is 60%. At induction of anesthesia, you will almost certainly be using 100% oxygen. Here is the bellows of the ventilator. This bellows must continuously go up and down during the case if you're doing controlled ventilation. This must be watched carefully. Directly in front of the bellows is a little green lever which can be switched from the left position or into the right position. This is to control the mode of ventilation. To the left gives you allows spontaneous ventilation, and flicking the lever to the right allows the ventilator to be activated for controlled ventilation or automatic intermittent positive pressure ventilation of the lungs. This round knob in the foreground is the APL, or the adjustable pressure release valve. It eventually controls a small leak, and by closing the valve you can increase how full the reservoir bag is. The reservoir bag is the bag you squeeze when you want to ventilate the patient, but ventilations will not be effective if the bag is flaccid. There must be a certain degree of tension. The bag must be slightly taut in order to effectively ventilate. So you can adjust the tension in the wall of the bag by adjusting this valve. I also like to make the point that whatever the tension is in the wall of the bag that you're feeling, that's the tension in the wall of the alveoli that you're ventilating. Let's identify some very important landmarks. Here we have the earlobe, and just above the earlobe is the angle of the mandible. This allows us to define the vertical ramus of the mandible and the horizontal ramus of the mandible. Note that the temporomandibular joint is not just a hinge joint. Interestingly, the entire jaw will descend a little and advance a little because it has a gliding action at a separate compartment within the temporomandibular joint. So again, we have the angle of the mandible and the earlobe. We have the vertical ramus of the mandible and the horizontal ramus of the mandible demonstrated here. Perform a simultaneous chin lift and head extension, but of course only if it's safe to do so. If it's not safe to extend the head, keep the head and neck in a neutral position. Carefully place the ring and little fingers of the right hand on the vertical ramus of the mandible directly above the earlobe. In the majority of our patients, it will be perfectly safe to extend the head on the neck. Then you place the ring and little fingers of your right and left hands on the vertical ramus of the mandible and lift gently but firmly directly upwards. Now, using ring and little finger of each hand to apply upwards pressure on the vertical ramus of the mandible, we are going to elevate the lower third of the face into the dome of the face mask. Upward pressure by the ring and little fingers of each hand are in fact opening the airway by displacing the mandible upwards or anteriorly. The ring and little fingers are holding pressure on the mask to form a pneumatic seal so that mask ventilation can be performed. The downward pressure must be enough to form a pneumatic seal so that there are no leaks, but not so much as to occlude the airway. This would defeat the purpose of what we're doing. Here is an example of this technique being used in the operating room. I like to consider that the left hand is holding the airway open while the right hand is breathing for the patient. If the green reservoir bag is becoming increasingly flaccid during the course of your manual ventilations, then it clearly means that you're losing volume from the breathing circuit. The simple explanation here is nearly always that you have a leak around the face mask, and that the pneumatic seal you are generating with your left hand is ineffective. So quickly go to two-handed ventilation, re-establish an effective pneumatic seal, and then return to mask ventilation with your right hand. This, of course, is easier said than done and requires much practice. However, you will get there in the end. We all do. When performing mask ventilation in the OR, the first thing we do is a chin lift with a head extension. Place the face mask on the face, ring and little finger of the left hand on the vertical ramus of the mandible, the same on the other side. Thumb and index finger on the mask, forming a pneumatic seal with the patient's face. Right hand on the green reservoir bag, ventilating the patient with a nice taut bag with plenty of pressure, but not excessive pressure, in the reservoir bag.